Um, I welcome you all to the International Speaker Program of the Indian Society of Pediatric Hematology and Oncology. Today we have an eminent speaker, come researcher in the field of neuroblastoma to deliver a top lecture on the topic Advancing Treatment for Neuroblastoma through Collaboration, a Pediatric Oncology Paradigm. We have Dr. Susan Lerner Korn, who is the professor of pediatrics in the University of Chicago and the Director of Pediatric Clinical Sciences in the Department of Pediatrics, Comas Children's Hospital in Chicago. Also, she is the co-chair for the INRG task force, and she has a lot of awards and honors for her clinical research. And she's also a member of various committees involving clinical research, especially neuroblastoma. To add to her credit, she has more than 200 publications, 52 reviews and editorials, 13 chapters in textbooks, and she herself has authored two textbooks as such. So I think there is no better person to talk on this topic on neuroblastoma. So on behalf of the Indian group of pediatric oncology, I invite now Dr. Susan to deliver the lecture. Thank you, ma'am.
Great. And I really appreciate the invitation, and I'm very excited to present this to you. I'm going to give you sort of a whirlwind. Let's see if why am I not being able to do this now? Hold on, I just shared beautifully before. Okay. I'm going to give you sort of a high-level overview of many of the advances that we've made in neuroblastoma clinical trials on at the very end some of the work that I've been doing internationally through the International Neuroblastoma Risk Group Consortium. These are my disclosures. So the North American Childhood Cancer Legacy of Progress has been demonstrated through the cooperative group collaborations that we've had. And we've had legacy groups called the Pediatric Oncology Group, the Children's Cancer Group, which all initiated about 50 years ago. And then more recently in 2000, everybody merged to form the Children's Oncology Group. So we're all working together now to collaborate. And as you can see in the United States, there's been tremendous progress over the last 60 years or so. And this is largely due to the success of cooperative group clinical trials that we've conducted that have leveraged the results of a previous study to define new standards of care. And so this iterative process has led to significant improvements in outcome. And I just thought I'd show you some data from SEER, the NIH registry. And I think everyone is well aware, and this is differences in survival between 75 and 2012. And everyone, I think, is very much aware of the significant progress that's been made in acute lymphoblastic leukemia. But as you can see, there are numerous other advances that have been made in many pediatric cancers, including neuroblastoma, which is the topic of today's talk. So neuroblastoma is the most common malignancy in infants. The median age of diagnosis is about 22 months. So these are young children that are typically diagnosed with this disease. The tumor originates in the sympathetic ganglia that will span from the neck to the pelvis, next to the vertebral bodies, as well as the adrenal medulla. What's so fascinating about this disease is that there's a very broad spectrum of clinical behavior, all the way from spontaneous regression to relentless growth despite intensive therapy. And this obviously reflects the biologic heterogeneity of the tumor. And this actually fascinated me when I was a very young trainee, and it was part of the reason why I went into pediatric oncology and to better understand the biology behind these very vast differences in clinical behavior. This has been recognized for a long time, this heterogeneity, and treatment has been tailored according to the predicted risk of relapse since the 1970s. And I'll just give you a little bit of history. Audrey Evans and Dan DiAngio published in 1971 the heterogeneity that they recognized, just taking into account the stage of the disease and the age of the patient. So both the extent of disease as well as the age of the patient was prognostically significant. And even in the 70s, they then modified treatment approaches based on these two prognostic markers. In the 80s, additional prognostic markers were identified. Importantly, NMYC amplification was discovered and published in 1985 by Bob Seeger and colleagues. Tumor cell ploidy was noted to be prognostic in the 80s as well, as was some seminal studies conducted by Hiro Shimada looking at histologic features. Now, since then, there have been numerous other genomic features that have been identified, and now as technology has changed, there's been whole genome studies and analyses that have been done that have demonstrated, for example, that copy number and segmental chromosome aberrations are also quite prognostically significant, and these have started to become integrated into our classification systems. Omic signatures, a variety of them, whether they be RNA, proteomics, or epigenomics, have been noted to be prognostic. Next generation sequencing has identified a couple of mutations, and particularly ALK, which is also an actionable mutation, but also has been demonstrated to have prognostic significance when it's amplified and or mutated. And then there's telomerase maintenance mechanisms that have also been identified that have also been demonstrated to be prognostic. Not all of these have made it into our classification systems, but I'm going to review where we're at today and again recognize that these classification systems are not static, and as we get more information and we're able to integrate new prognostic markers, they will be integrated and refine the system. We published a little bit ago sort of a history of the classifiers that have been identified for neuroblastoma. And as I mentioned, way back when in 1971, Audrey first used age, and she age at the diagnosis, as well as what she defined as Evans stage of disease. The staging system has been modified over the decades. The Pediatric Oncology group had a surgical staging system that they developed. The Children's Cancer group ended up adopting the Evans staging system, which was a more of a radiologic staging system. And then the two legacy groups merged, initially started working together in 1998, and then formally merged in 2000 to form the Children's Oncology group. And the COG in 2006 developed a classifier that included age, INSS stage, which is the surgical staging system, MIC-M status, DNA ploidy, and histology. And this is what the 2006 staging classification system looked like. And depending upon the age of the patient, the stage of the disease, the presence or absence of NMYC amplification, and these other features, patients were classified as either low, intermediate, or high risk. And then subsequently, clinical trials were designed, and the intensity of therapy and the length of therapy very much varied. The drugs that were used varied depending upon the risk group that the patient classified. So these are data for more than 20 years ago. And this is sort of the combination of data that was collected through 1986 to 2001 that included the legacy groups as well as COG groups. And you can see even 20 years ago or so, patients who were classified as low or intermediate risk who were treated during this era had a really excellent event-free survival, whereas patients that were high risk had long-term survival of approximately 20%. So over the past 25 years, what has been done in the Children's Oncology group is we've tried to reduce therapy for low and intermediate risk patients and hopefully maintain their excellent outcome with less therapy that would be hopefully associated with less side effects for these very young children. And of course, high-risk patients required something different. And we've done a number of studies looking at increasing intensity, as well as adding in some new, very effective drugs, and particularly anti-GD2 antibody. Now, this was all fine and dandy for North America, but it was very clear to me that this is pediatric cancer is rare, And again, to kind of go along my theme of the whole talk in terms of interaction and collaboration, I really felt that we needed to have international collaboration. And Andy Pearson, who's pictured here, and this is what I looked like a while ago, we were asked to hold a meeting to bring together the investigators from all over the world to meet in Canada to see if we could come up with some unifying risk schemas so that everybody would end up defining risk the same across the world. And then that would help us directly compare clinical trials, because at this point in time, what COG classified as high risk was not what some of the European countries classified as high risk, or Japan classified as high risk. So it was not possible to directly compare the clinical trials. So the goal of this meeting was to develop a common data dictionary and a pre-treatment risk classification schema. And Tom Montclair, who is right here, who is a surgeon from the Netherlands, or from Norway rather, he was at the meeting, and he was really, really, really emphatic about needing a new staging system because the INSS is based on surgery, and we wanted a pre-treatment staging system, which would require not having surgery to determine the stage. He really felt it was not appropriate for the stage to be dependent on whatever institution you happen to go to and the aggressiveness of the surgeon. So we also developed a new staging system that was based on scans, very much what Audrey Evans did way back when. There's a lot of, as I've gotten older, I've realized there's more and more deja vu as we've tried to make additional progress. So this is the staging system. I'm sure you're familiar with it. It was published by Tom in 2009. It's called the INRG staging system, and this is a pre-treatment staging system that's based on imaging, and it's dependent on whether or not there's what are called image-defined risk factors, and these are risk factors that would make surgery much more difficult up front. And it's very intuitively logical. For example, here's an example of a CT showing encasement of the one of the major vessels. And this would obviously make surgery of this particular tumor incredibly difficult. This patient also happens to have intraspinal extension of the tumor with more than a third of the canal, and cord compression, which is another image-defined risk factor. So the way the staging system works is that your L1, a localized tumor, 1, if you don't have image-defined risk factors, L2, if you're a local regional tumor with 1 or more image-defined risk factors, stage M is distant metastatic disease, except for MS, which is analogous to INSS 4S, in which the tumor is either an L1 or L2 for the primary tumor, and the metastatic disease is confined to the skin and/or liver and/or bone marrow. And this is the risk classifier that was published in 2009. Again, we used INRG stage, and this risk classifier was developed based on an analysis of data that was collected from over 8,800 patients from around the world. And we took a look at all the various prognostic factors that had been identified, and this new staging system, and age remained in the classifier. We did not use the INPC, or the International Path Classification System, for this particular staging system. Instead, we used histologic category and the grade of differentiation. NMIC status was included. 11q aberration, present or absence, was included, ploidy. And as you can see, patients were then classified to either very low, low, intermediate, or high risk, and then various countries could develop clinical trials that would correlate with these various rows, and we'd be able to hopefully compare, for example, somebody who was classified as C, very low risk, based on these factors in Europe and in Japan and in other countries around the world, if everybody used the same classifier. So here we are, 2009, and we developed this classifier. And then initially, COG wasn't able to switch over to the INRG staging system because we had a number of clinical trials that were ongoing where we had defined risk according to the 2006 COG classifier. But then a couple of years ago in 2021, we finally revised our classifier to be analogous to the INRG classifier. This was published in JCO by Meredith Irwin and colleagues. And as you can see, we made in the paper, there's these nice flow diagrams, which I think make it a little bit easier to try to figure out what particular risk group your patient belongs to. Here's a patient who has an L1 tumor. You first take a look at what their age is. You then take a look at the diameter of their tumor. There is open at this time a study in COG for observation. If the tumor had a gross tumor resection, patient was low risk. Here you can see a tumor that was not completely resected, and if it's NMIC amplified, the patient's high risk. And so you can go through these flow diagrams and very nicely determine which risk group a patient is assigned to. L2 tumors included factors NMIC status, age, histology. And in this particular classification system, we did use the INPC, so favorable, unfavorable histology, ploidy, and whether or not there were segmental chromosome aberrations. And here's stage M. You can see the biomarkers and MS. We also, for MS, symptoms were included as one of the biomarkers to determine which risk group a patient was assigned to. So if you take a look at risk group treatment, again, this is over the last couple of decades, we have seen that for patients who are lower intermediate risk, survival rates are really excellent. More than 90% of the patients are successfully treated with surgery and moderate dose chemotherapy. And there's a subset, and I'm going to show you some of the data of low risk patients that actually don't even require surgery to be cured. And then the high-risk patients, we've been modifying therapy over the last couple of decades, and we have been able to demonstrate that some of the changes that we've made in our clinical trial treatment approaches have also improved outcomes, although long-term survival rates still remain at less than 60%. So while that's substantially better than 20%, we still have a ways to go. And I thought I'd just show you some of the highlights of the studies that were done. This is the last low-risk study that was conducted by the Children's Oncology Group. So if you were classified as low risk and you were asymptomatic, you received surgery alone. If you were symptomatic, and these were largely stage 4S patients that were low risk but were otherwise symptomatic, with most commonly related to enlarged liver and respiratory distress. They received 2 to 4 cycles of moderate dose chemotherapy and surgery. And you can see their overall survival is truly outstanding, as was their event-free survival on this study, which was published in 2012. Now, as I mentioned, there's a group of low-risk patients that don't even require surgery, so you can really decrease therapy substantially. I'm sure you're all aware of the screening studies that were done several decades ago in Japan, Canada, and Germany, where babies were screened with urine VMA HbAs. And what was noted was that there was an increased rate in the diagnosis of neuroblastoma. However, there was no decrease in mortality. And virtually all the tumors that were identified with urine VMA HbAs in infants were favorable biology tumors. And so the conclusion was that these tumors that were diagnosed by screening, mass screening, were unlikely to progress to life-threatening advanced stage disease, and many were likely to spontaneously regress because there was an increased rate of diagnosis. So we conducted a study in the COG where we used observation as the primary therapy for young infants with suspected neuroblastoma. This was opened between 2001 and 2010. The infants to be eligible had to be less than 6 months of age with a localized adrenal mass. A wait-and-see approach was taken. Surgery was performed if the tumor mass increased by 50% or if the catecholamines remained elevated for more than a year. And these are the results. You can see the overall survival and the event-free survival are truly excellent. And the green line here is the relapse, the refractory-free survival, so the resection-free survival. So these 80% of the patients never required any surgery whatsoever. A number of them did receive surgery either because they had progressive disease or because parents insisted on having surgery. But but the vast majority of the patients did really well with no surgery whatsoever. The recently completed intermediate risk study is ANBL 0531. The objective of this study was to reduce therapy for subsets of patients with intermediate risk disease, and then the outcome was compared to legacy studies, and they were selected based on a biology and response-based algorithm. And the hope was that they would be able to maintain 3-year event-free overall survival by 95%, even with the reduction of therapy. And these are the results. This was published in 2019 in JCO. And again, you can see that the overall survival was really, truly excellent. There were patients who relapsed, but many of them were successfully salvaged. So again, we were able to successfully reduce therapy while maintaining excellent outcome for these intermediate risk patients. We recently followed up on the original study, and we just in the last year published long-term follow-up of these patients. And you can see with more than 10 years of follow-up, these survival curves are maintained. Taking a little bit of a deeper dive, we did see that there were patients who had stage 4 disease that were considered intermediate risk. And they had worse survival compared to the non-stage 4 intermediate risk patients. So stage 4 disease patients had a little bit of a worse outcome, intermediate risk stage 4 disease patients. And we also found that infants who had stage 4 tumors who had unfavorable biologic features also did worse than patients who had favorable biology tumors. So there is this little subset within this intermediate risk group where we still need to think about how we might be able to improve the outcome for this small subset of patients. Now, high-risk patients have remained a challenge. I just thought I'd run through some of the successes and the clinical trial results that we've had over the last several decades. I'm sure you're all aware of the seminal paper that was published by CCG, led by Kate Mathey in 1999 in the New England Journal of Medicine, where they randomized patients in this 3891 study to either receive high-dose therapy and stem cell transplant, followed by post-consolidation retinoic acid, versus just chemotherapy, but not the high-dose therapy and stem cell transplant. And the study demonstrated that the kids that were randomly assigned to the stem cell transplant had improved event-free survival, although still there was a long way to go in terms of being excited about the curve. It was still not a very high survival curve, albeit better than the kids who received the chemotherapy. In 2010, we did another study, another randomized study, which also ended up being quite seminal, where we tested immunotherapy with anti-GD2 antibody plus cytokines following consolidation, so following stem cell transplant. And this was also published in the New England Journal in 2010 and demonstrated there was significant improvement in both event-free and overall survival for patients that were randomized to the immunotherapy arm. This data was later taken to the FDA, and this was the first therapy that was ever approved by the FDA for high-risk neuroblastoma in March in 2015, and the drug is now called dinutuximab. Once the randomized portion of 0032, which was comparing antibody and immunotherapy versus no immunotherapy, was completed, we then kept the study open because the immunotherapy arm was so successful. And on the non-randomized arm, we enrolled 1,183 patients, and they were non-randomly assigned to immunotherapy between 2009 and 2015. And you can see the 2-year event-free survival and the 2-year event-free survival and overall survival is really excellent. It's substantially improved from what we've seen in the past. I do want to remind you, this is not from diagnosis. This is from time of enrollment onto the study. So to be enrolled on the study, you've already made a 3-year consolidation, and you do not have a lot of active disease to be enrolled on the study. So this is, again, not from diagnosis, but it was nice to see that the event-free and overall survival curves were maintained. The next study that we took a look at was asking a question, is more better? So because transplant appeared to be better in terms of outcome than chemotherapy alone, a study was initiated by the COG in 2007 to test whether tandem cycles of myeloablative therapy and stem cell rescue would improve event-free survival over a single transplant. And patients were randomly assigned to either tandem or single transplant after induction therapy. And as you can see, and this was published in 2019 in JAMA, those patients randomly assigned a tandem transplant did substantially better than those who received single transplant. A subsequent analysis was done to take a look at how stem cell transplanted benefited patients who also happened to receive dinutuximab. And you can see if you had tandem transplant followed by dinutuximab, your survival curve again was significantly better than those patients who had a single transplant followed by dinutuximab. However, we didn't see any difference in overall survival. Now, it may well be with further follow-up, we will start to see some differences. We think part of this is because we now have therapy that some patients have received after relapse that has been effective in extending their survival. So with time, we'll see if the tandem transplant also ends up leading to improved overall survival. But as of the data that were published right now, this is not the case. So here's what we consider our standard of care based on these results. Everybody receives induction therapy, tandem transplant, radiation, and then are consolidated with retinoic acid and immunotherapy, a la ANBL0032. And I just thought I'd show you that we have made some progress from the original high-risk curve that I showed you way back when we were here at 20%. So over these various eras, you can see there's been substantial improvement in both event-free survival as well as overall survival, which is very gratifying. However, if you take a look at this dotted line, 2015 to 2019, we're still seeing 40% of the patients relapse and die. So we still have more to do, and we have to do a better job of improving therapy for all patients. Now, this very intensive therapy takes a toll, and this study looked at kids who were diagnosed between 1970 and 86. So these are very, very old patients treated a long time ago. Most of the high-risk patients are not even included in this cohort because they would have died. As you know, as we mentioned, only 20% of high-risk patients lived during this era. And this paper was looking at long-term outcomes of survivors of neuroblastoma. This is a children's cancer survivor study. And what they found, even patients treated decades ago, the survivors had increased rates of mortality in second malignant neoplasms compared to sex and age-matched controls, increased risk of chronic health conditions, and they were less likely than their siblings to have ever been employed or married and had a lower personal income. So chemotherapy and the therapy they were using way back when had very serious adverse events on our survivors. My colleagues Tara Henderson and Lisa Diller are now trying to take a look at what's happening to treatment to patients who are treated in a more modern era. This was a COG study that they initiated in 2016, and they're evaluating adverse events in patients who were treated after January of 2000 with more modern therapy. This study is ongoing. They've been collecting treatment exposure data, medical records, and various surveys and full-day clinical evaluations are being conducted. And some early results have been presented at various meetings like ASCO and the Advances in Neuroblastoma Research meeting. And one of the things that's come out is that there's severe ototoxicity requiring hearing aids in 63% of the patients, which was really quite surprising because I don't think many of us felt that the ototoxicity was quite this severe. I know that the study is just about ready for publication, and hopefully we'll see a more detailed report of what they found in the very near future. The other thing I want to bring up is that response at end of induction is very highly prognostic of outcomes. So if you have greater than a partial response, your event-free survival and overall survival is much better than if you didn't respond. And so this, of course, leads to the question is there a way for us to improve end of induction response? And if we did improve that, would that lead to better outcome? So there are a number of different therapeutic approaches for targeting neuroblastoma that have been described over the last several decades. And I'm going to just initially talk about targeted radiotherapy with MIBG, radio-labeled MIBG, and also talk about some tyrosine kinase, in particular ALK inhibition. And we tested both of these targeted therapies in our recently completed study, high risk AMBL 1531. The patients were randomized to either receive our standard of care therapy, which I just showed you, that included tandem transplant, followed by immunotherapy, or they had a cycle of radio-labeled MIBG in induction, followed by standard of care consolidation and post-consolidation, so arm A and arm B. If you did not have MIBG avid disease, which happens in 10 to 15% of patients, and there was no ALK aberration, then you receive standard of care therapy without the MIBG. And if your tumor was noted to have an ALK aberration, then you were treated with lorlatinib, which is a third generation ALK inhibitor, after cycle 2 onward. And this arm is ongoing. The study was completed in accrual in 2023, and we hope to have results, and we'll learn in the next within the next year or so whether or not adding MIBG therapy to induction led to improved outcome. The other therapeutic agent I just want to mention is DFMO. This is right here. It's an ornithine decarboxylase inhibitor, which is a target of NMYC. And it irreversibly inhibits ornithine decarboxylase, which I mentioned is downstream of NMYC, and it's a key enzyme in the polyamine synthesis pathway. And if DFMO depletes polyamines that are necessary for tumor survival, and there have been mouse models that have demonstrated that the administration of DFMO improves survival in these mouse models. So this study was taken, was conducted in the Beat Childhood Cancer Consortium. This is not the Children's Oncology Group. It's a separate consortium. And what they did in this study was they had conducted a study, a single-arm phase 2 study, where they gave patients DFMO for 2 years at the end of denatuximab. So patients were treated with our standard of care therapy. And then if it looked like they were in remission, they were enrolled on this study for 2 years. And this study was reported, the results of the study was reported as a single arm. But of course, it was very difficult to know whether these patients would have done well or not done well without the DFMO because it was a single arm study. So what was done was they compared the results of this study to an external control arm, which was on 0032. So these are patients who were treated like this. They were enrolled on the antibody study, but they did not receive DFMO. So you're comparing patients who received DFMO or who did not receive DFMO after immunotherapy. And this study was published within the last year in the Journal of Clinical Oncology. They looked at both unmatched and matched study populations. And by matched, they used a propensity score matching for 11 covariates. So patients were on the Beat Childhood Cancer protocol were matched to 3 patients in 0032 who did not receive DFMO by age, sex, race, stage, pre-transplant response, the transplant type, overall response at end of immunotherapy, and MEC. And here's the unmatched data, which showed that if you did not receive DFMO, you had worse event-free survival and overall survival compared to those who did. And again, if you look at the matched populations, very similar findings were identified. And so this led to the FDA approval of L-ornithine for adult and pediatric patients with high-risk neuroblastoma post-consolidation in 2023. Now, if you do relapse and you have high-risk disease, if you take a look at how patients did who were enrolled on COG studies during this era, you'll see that the outcomes are really dismal. And in fact, 4-year progression-free survival was 6%, and 4-year overall survival was 20% for all patients if from the time of early phase enrollment. So really terrible outcomes if you relapse, which is why we're trying so hard to treat the patients more effectively the first time. Now, after that study was published, looking at those results, we did do a phase 2 study in COG between 2013 and 2017, where we used a backbone of temsirolimus and antibody, and patients were randomized, a backbone of chemotherapy consisting of irinotecan and Temodar. And then patients were randomized to either receive temsirolimus or antibody. And what we found was that there was a significant response rate in the patients who received dinutuximab, with 9 of 17 patients achieving either a PR or a CR, whereas this was not the case in the temsirolimus arm. So this really did look like, for the first time, we had an effective regimen in the setting of relapsed and refractory disease. And there was an expansion cohort that the results of which were published in 2020 in the Journal of Clinical Oncology. And as you can see, this survival curve and event-free survival curves look substantially better than the curves that I showed you from the previous generation of phase 1 studies in relapse and refractory disease. So we're very, very excited about this, and antibody clearly combined with chemotherapy seems to be quite effective. Now I mentioned the DFMO. We did have a relapse study that was ongoing, looking at chemotherapy and dinutuximab, and we randomized patients to also receive chemotherapy, dinutuximab, and DFMO, given the results that were seen with DFMO. So this was randomized, Arm A and Arm B. The study was recently completed, and the results were presented at the most recent ANR meeting, which was just last month in Washington, D.C. There were 91 evaluable patients, and in this setting, the DFMO did not make a difference. And this is very different than the post-consolidation setting, when there was no evidence of active disease following antibody. But in this setting, and they were upfront patients, but in the relapse and refractory setting, the addition of DFMO did not improve response rate and did not improve progression-free survival. We did, however, see more toxicity in the patients who received DFMO, and they had significant increases in hearing loss that required the dose being held. But based on the very exciting data that we saw with antibody and chemotherapy, there's now a new study that just recently opened. Again, we're randomizing patients, and here patients are receiving induction alone with chemotherapy, or induction chemotherapy with antibody from cycles 2 to 5. And then if you have what's called a good early induction end response, which is basically a PR. So I showed you that response at end of induction is important. So if you have a good response to induction here or here, you then get standard consolidation with tandem transplant, and then standard post-consolidation immunotherapy. And then we're amending the protocol right now to add on DFMO post-consolidation based on the FDA approval of the DFMO. If you don't have a good response, patients can then get irinotecan, Temodar, and dinutuximab to try to improve their response. And if they do get a good response, then they can go on to receive post-consolidation and consolidation and post-consolidation. So this study is ongoing, and we will have results hopefully in the next couple of years. I did want to bring up this paper that was published in Pediatric Blood and Cancer in 2022 by advocates. These are all parents of patients with neuroblastoma. And what they wrote in this commentary piece was they recognized transplant has improved event-free survival, but they also recognize that this treatment's associated with risk of serious acute and long-term toxicities. And they're also were aware that randomized studies have not demonstrated overall survival benefit of transplant. Like I mentioned in 0532, there's an advantage in event-free survival, but not overall survival. And they comment in there that there's been debate among parents and advocates and some physicians regarding the merit of stem cell transplant in the modern era of immunotherapy. And so it's really brought up a lot of questions. And what they challenged research consortia in this paper to do was to develop a coordinated strategy to accelerate progress towards a future that hopefully can avoid stem cell transplant and all the toxicities that we know are associated with it and still have effective high-risk therapy. So Andy Pearson and I, who co-chair the INRG consortium, wrote a response to their piece. And we did agree with them that the efficacy of consolidation with immunotherapy versus stem cell transplant needs to be scientifically evaluated. There are centers like Memorial Sloan Kettering that do not use stem cell transplant and use immunotherapy, but these are single-arm studies. They've never been randomized, and they've never really compared their results to standard of care therapy. So COG, I'm happy to say, has started to think about developing a randomized phase 3 study. This is in the works. This study will not open until the study I just showed you, where we're adding antibody to induction, is completed. But we hope to have this study ready to rock and roll so that as soon as that study is completed, we'll be able to open this study. Patients on the study will get induction chemotherapy. If they had a good end induction response, they will get randomized to either receive standard consolidation with tandem transplant, radiation, and standard post-consolidation, or they're going to get chemoimmunotherapy, temodar, irinotecan, and dinutuximab for 6 cycles, followed by radiation, and then post-consolidation therapy with antibody, and then also add in DFMO. We're hoping this opens in 2027. And, if this study demonstrates that even if it's not better in terms of event-free survival, if it's similar and we can avoid transplant, we would consider that a win. I do want to mention just briefly, this was largely North American data that I was discussing. But as I said, I'm very much convinced that international collaboration is also going to be necessary for us to make further progress in this disease, particularly as we start to look at smaller and smaller cohorts of patients. For example, patients who have ALK mutations in their tumors that potentially are going to be treated with ALK inhibitors. That's a different category of patients. It's only 10% of all the neuroblastoma patients that are diagnosed. There's no way for us to be able to really make meaningful statistical analysis in these small cohorts without collecting data together and collaborating together. And I'm very pleased to hear that Sam Volchenbaum is going to be visiting India again. I know he was there recently. He's going to come again to talk about this, and we're very anxious to see if we can get more data collected from other countries beyond Europe, Japan, and North America, which is where we collected the vast majority of our data to date. So we have, like I mentioned, we collected data on 8,800 patients to initially develop the risk schema. And we also have developed data sharing policies so that the data that we collected for the risk classifier would be made available to investigators from around the world. We've continued since that time, since 2009, we've continued to collect data from the various cooperative groups around the world. And I'm very happy to announce that we currently have data on more than 25 patients housed in what is called our iEnergy Data Commons, which is an ecosystem that can house data and link to other databases. And these data are available to the research community if you have questions that you'd like to ask. To date, there have been 40 studies that have been done, including analyses on rare patient cohorts that previously were not possible without these large number of patients. This networking model that we've established has led to new discoveries and actually changed some treatment strategies. And the model is an exemplar for other pediatric cancers and rare adult malignancies. And so I thought I'd show you just a schematic of what this pediatric iEnergy data commons looks like. It's an ecosystem that's in the cloud. And as I said, we have patient data there, iEnergy patient data, and the data are uploaded by various cooperative groups. We've most recently added data from St. Jude. There have been patients at St. Jude that were treated that were not treated in one of the cooperative group studies that have now been added to the iEnergy patient cohort. And this iEnergy cohort sits in a infrastructure that's called the Pediatric Cancer Data Commons, and this contains data from other cancers as well. And there are analytic tools within this cloud environment. The cloud environment enables links to external data sites. So if we, for example, in COG, we can link COG patients to the NCI genomic data commons that have data on some of the patients' germline as well as their tumor samples, and as does Gabrielle Miller Kids First. And there also are some connections to GEO for some of the SciPin data. So researchers can conduct cohort discovery. So you might be interested in stage 4 patients with ALK mutations, for instance. You can go into this cloud. You can say how many patients in the iEnergy data commons have stage 4 disease and ALK mutations, and you can get an answer as just a cohort discovery, how many patients there are. You can do a little bit of analysis actually in the cloud. So for example, you can take a look and see what their survival is compared to stage 4 patients that don't have ALK mutations. And then if you actually want to do a research project and really dive in deep, you can receive patient level data through an application process. And I would just encourage you to go to ienergydb.org. This is our website. If you click on the research tab, you'll see a list of all the ongoing and previously published research studies that we have done. There's links actually to the PDFs if the studies have been published. There's also links to some of the abstracts if the studies have been presented at various meetings. And there's also a link here for getting involved. So we're very interested in having investigators from all over the world think about questions that they might be able to ask using this data. The data is different than clinical trial data. And so this Get Involved button will link you to a member of what we call our strategy committee, which is a mentorship committee who can kind of help figure out whether the question you want to ask is feasible, not feasible, and then we can help you hopefully develop a project that gets approved, and then you can actually do the analysis if that is what you'd like to do. We're also interested, obviously, in collating more data. I know in India you have many, many, many patients, and I believe Sam Vochenbaum is going to be visiting you, and we would love to hear whether or not it'd be possible for us to potentially have you think about uploading patient data, not only in neuroblastoma, but as Sam will explain to you, we currently have also sarcoma data, and we're in the midst of getting additional lymphoma data, some ALL data, et cetera. So the more data we have, the more data we share, I think the faster we'll be able to accelerate progress. And we do have all sorts of contracts that we can go over with you to make sure that we're following all the restrictions and the rules according to your government for data sharing. So with that, I'll end. I just would like to acknowledge all my iEnergy colleagues, my COG colleagues, of course, Sam and his team at the University of Chicago. We've worked very closely together over many, many years now to build this out. We're in the process of trying to also use the electronic health record data to upload more detailed clinical data into the iEnergy, and I've got a couple of projects ongoing with that. And so we'll see if that takes off. It may be possible for us to also not only just use clinical data from clinical trials, but also electronic health record data. The parents and patients who have signed consents who have allowed us to do this, and all of our support for this project. And with that, I'd be happy to end this and answer any questions.
Okay, thank you, Dr. Susan. That was a wonderful talk, and it is exciting to know that good international collaboration and ongoing clinical research is really improving the outcomes for this really difficult disease. The moment we hear stage 4 neuroblastoma, yeah, it's really a difficult situation to handle. If you have time, we will go through the questions in the chat box. Yes?
Sure.
Thank you, Dr. Susan. It was an amazing lecture, and I think you brought everything about neuroblastoma together in these 45 minutes. Very, very helpful. Before Vinod and Badira start taking questions, I just wanted to make a quick announcement that the next lecture will be on Ewing sarcoma, the national PHO training in 2 weeks, and it is going to be a panel discussion. And Vinay and Shruti are really putting hard work together to get many famous national colleagues who work in this field. So please do attend and you'll get the information very soon. So over to Vinod and Badira for the question answer session. Thanks again, Susan. Thanks a lot.
Yes.
Thank you, sir. So, question from Dr. Satyendra Kateva. Like the data suggests that DFMO works when stem cell transplant and GD2 have been given already. But now COG has designed a study where even good early responder will be given no transplant but just anti-GD2 plus DFMO. Can we really expect that our understanding will change with this approach?
Yeah, it's not just antibody, it's chemotherapy plus antibody, which has been shown to lead to really high response rates in patients with relapse and refractory disease. And what we've done over the decades is anything that works in the setting of relapse and refractory disease, we have tried to move that up front. So I know everybody thinks that stem cell transplant is standard, and it has been standard for 50 years. It's more therapy, very, very intensive therapy. What we're substituting and what we're going to test in a prospective randomized study, it may not work. It may be that tandem transplant's better than chemotherapy plus antibody, but we will test this and find out. And I want to try to have you think about chemotherapy and antibody as different therapy, not decreased therapy. But it's been shown to be very effective. And if you take a look at what's been done with our adult counterparts, there are many, many adult diseases now that are treated with checkpoint inhibition and various immunotherapy regimens, and they don't get chemotherapy anymore. And I just feel that we've been doing this for 50 years, and we've been building on the fact that more is better, and that's been our practice for a long, long time. And our current study will continue that. Our current study, we're randomizing, adding in antibody during induction. And everybody's still going to get a tandem transplant and still going to get, post-consolidation antibody. So the study that, like I said, that we're planning isn't going to open still for a number of years. And as I said, we will have stopping rules built into this randomized study. So if it turns out that the relapse rate is substantially higher in the chemoimmunotherapy arm, the study will be stopped. But we will never learn whether the Sloan Kettering approach, and they have been, for 20 years now saying you don't need to transplant patients and you can just use, immunotherapy and patients do well. And I can tell you, I have personally had parents who have refused transplant at the University of Chicago, and I've treated them with chemoimmunotherapy. And it's not a study, it's not a prospective clinical trial, it's anecdotal. I have patients that have continued to do very well. Whether they're cured or not, I won't know for several years, but they have become long-term survivors. So it's absolutely clear that there are some patients that do not require transplant to be cured. I hope that as we get better with our biomarkers, we'll be able to determine which patient really requires a transplant to be cured, which patient can be cured without a transplant, which patient will have excellent response to chemoimmunotherapy, which patient won't, et cetera, et cetera. So there's still a lot to do, but unless we conduct this prospective randomized study and compare the two arms, we'll never know. And we'll just keep arguing it. We'll keep arguing about it. So please think about this as different therapy, not less therapy.
Thank you. The next question from Dr. Prachi regarding the role of lutetium-177 and MIBG therapy in neuroblastoma.
Yeah, we haven't done much looking at the lutetium-177 yet in the United States or in North America. As I said, the MIBG therapy question will be answered when we get back the 1531 results, which hopefully will happen in 2026, and we'll know if we add MIBG therapy into induction, which again is more therapy, right? It's another more is better type of approach. We will learn whether or not adding in MIBG therapy does indeed lead to improved event-free survival. So we're very anxious to learn about that. If that study does show that MIBG therapy is better, then I suspect the study that's going to open looking at the consolidation question will end up adding MIBG therapy also into induction. So we'll incorporate, a different induction with MIBG therapy if that study shows that the MIBG therapy is a winner.
So, difficult question. Next thing is, if dinutuximab is not affordable, can you suggest a strategy for high-risk neuroblastoma in a resource-limited setting?
I'm sorry, are you looking at the role of MIBG?
Yeah, no. After that, like dinutuximab is not affordable. Your strategy for a child with high-risk neuroblastoma in a resource-limited setting.
I'm sorry, are you saying you are unable to get MIBG scans?
No. So we are saying that if dinutuximab is not affordable in a resource-limited setting, then what are your options for a patient with high-risk neuroblastoma?
Oh, if dinutuximab is not available?
Yes.
Yeah, there are other antibodies. I know, dinutuximab beta, for example, which is used right now in Europe. I know that the company is Recordati is the company, and I know that they're very much looking to try to license that particular antibody. And there are a number of other antibodies that have been developed, anti-GD2 antibodies. I think, if you don't have antibody, you don't have antibody, and that's obviously an incredibly important part of the regimen. That's the antibody upfront, post-consolidation, as well as being used in the setting of relapse and refractory disease is really been one of the biggest transforming treatments that we've had in neuroblastoma. So I would hope that you'd be able to, discuss this with some of the pharmaceutical companies that are making antibody and see if you might be able to eventually get antibody in the country. Even if you had one or two centers that could have antibody, then potentially patients could travel to get the antibody. If you don't have it, you don't have it, and then you just have to treat according to the, previous regimens that we had, and without the antibody. And, I would imagine that the success rate will be less. But hopefully, as the antibodies get approved and licensed by other companies beyond United Therapeutics, they'll become more available.
Like any special consideration for older children or adolescents more than 18 years with high-risk neuroblastoma?
Yeah, that's a huge problem. I'm sure, as you're aware, high-risk neuroblastoma in the older child and adolescent is quite different than younger children neuroblastoma. The disease is much more indolent. It's much more difficult to treat. What we have been doing is we've been starting with high-risk induction chemotherapy for those patients. And then we look at their end of induction response. There are rare older patients who will respond to chemotherapy, induction chemotherapy. And if they do respond, then we do go on and treat them a la our standard of care therapy with stem cell transplant and then post-consolidation immunotherapy. If they do not respond, though, and if their end of induction response is very poor, what we have been doing is not moving forward with additional stem cell transplant, and we've been treating those patients with chemotherapy and immunotherapy. I think if you don't respond to induction chemotherapy and your tumor is relatively chemo resistant, resistant, there's very little reason to move forward with higher doses of chemotherapy and transplant. These kids have continued to be very difficult to treat. However, they tend to have longer survival rates, but eventually, unfortunately, most of them do end up dying from resistant disease. And I don't think we have enough information yet about how they do with chemoimmunotherapy. This might be something that we potentially could look at eventually with the INRG data, if we can collect EHR data and determine how many adolescents got treated with chemotherapy and immunotherapy. And this is the kind of data that I think would be incredibly helpful if we get some more information. There's no clinical trial per se right now for us to get data from clinical trials in this population, but this might be something we could do in the future if we end up getting electronic health record data and collect this treatment data. So the jury's out as to whether or not chemoimmunotherapy is effective in the older population, but this population tends to be quite resistant. Many of them, as you know, have ATRX mutations, which affects telomerase mechanisms, and I know there's a number of potential new drugs that are being looked at that might be able to interfere with some of these telomerase mechanisms, but these are all right now experimental in phase 1.
If you have time, maybe next question. It's a clinical case scenario, 2-year-old with L2 disease with the unfavorable histology with segmental chromosomal aberrations positive. So here the question is the optimum number of cycles, cycle 4 versus cycle 8.
So if they're a 2-year-old, and they've got 11q and 17p gain, not LOH, not amplified, and it's unfavorable. So if a patient has an L2 tumor with unfavorable histology, that's actually considered high risk in COG. And what we have done for those patients is we've treated them in the past protocol 0532, where I showed you the results. Those patients were eligible for that particular protocol, and they received a single transplant, not a tandem transplant. They were non-randomly assigned a single transplant. So those patients received induction chemotherapy and single transplant and post-consolidation antibody. And we've been treating those patients with transplant. In Europe, those patients have been treated with chemotherapy and not transplant. And if you take a look at the results, they're actually very similar. So it's very difficult to know exactly what the best treatment is, but in our hands, like I said, our tendency has been to be a little bit more aggressive with those patients because of the unfavorable histology. And anyone who's over 18 months with unfavorable histology with an L2 tumor is typically treated with a transplant. There's a task force right now to take a look at how we might be able to, perhaps this might be the first population we ought to consider not transplanting and using chemotherapy, immunotherapy instead. So there's a lot of discussion about whether we should do a study specifically for these patients, remove the single transplant, use high-dose induction chemotherapy, and then follow it with chemoimmunotherapy. So those are the kinds of things that are being talked about. But this is what happens when you have a very small cohort. This is another example of where INRG data, I think, will be very helpful, because you can take a look at this very rare cohort, over 18 months, not NMIC amplified, L2 tumors, and take a look at what biomarkers might be able to impact outcome.
Next quick question on any group studying anti-PD-1, PD-L1 inhibitors in neuroblastoma.
Yeah, there's, as you know, to date, these checkpoint inhibition drugs have not been very effective as single agents in neuroblastoma and other pediatric cancers as well, except Hodgkin's disease. But in Madison, Paul Sundell has a study going on right now where he's using, it's a phase 1 single arm study where he's using MIBG therapy plus denatuximab plus checkpoint inhibition, and to see if you combine, radiation and checkpoint inhibitors and antibody if we'll see a response. So that study is ongoing. I think he also presented some of that data at ANR in June, and there have been some responses. Not a home run, not the way the DIT was a home run, but there have been some responses. So more to come. Clearly, the checkpoint inhibition alone is not effective, even if the tumor is P53 mutated. I know a number of patients have been treated with checkpoint inhibition if their tumor is P53 mutated, which is rare. Most are not, but it's been relatively ineffective. So there needs to be some kind of combination to try to overcome the immune suppressive environment that we know is present in neuroblastoma.
Next from Dr. Purna, ma'am, the comments on Japan study on KIR mismatched transplant as a substitute for immunotherapy, again, which is beyond the reach for LMIC.
Right. I mean, there are some things that just, of course, can't be done. And this is also a, this is an experimental single arm kind of thing. This is not what I would consider standard of care. I mean, I showed you what COG considers standard of care, and I realize you can't get the antibody everywhere, which is, really, really, problematic in terms of, the effect it'll have on survival for this subset. So I would really do whatever you guys can do to talk to various companies and see if they would be able to provide some antibody for you and at least maybe have a couple of centers. I realize your country's huge and the travel is enormous, but if you could have antibody available at some key centers across the country and then patients could travel, that would be great.
I think the next question on adolescent has been discussed. Then we move to Dr. Prashant's question on additional cycles of induction to improve the local tumor control.
Wait, say it again.
Additional cycles of induction helps bringing the children to metastatic remission. Similarly, will intensifying the induction improves the local.
Yeah. So again, what we have been doing, and we're using this good early induction response, which is essentially a partial response. What we've been doing is at the end of induction, and right now we're using 5 cycles of induction, and you get a full workup at the end of 5 cycles. If you do not have, we don't use metastatic remission, but we use, as I said, this good early induction response, which is essentially a partial response. So you might have an MIBG score when you were diagnosed of 10, and now your MIBG score is 3. That would be considered a partial response. So you still may have a couple of sites of metastatic disease, but if you meet this good early induction response criteria at the end of induction, then you move forward with your transplant. If you don't meet that criteria, you have stable disease or less than a partial response, we have been treating patients with chemotherapy plus immunotherapy. So we haven't gone on with additional cycles of induction chemotherapy alone. And if you treat with chemotherapy plus immunotherapy, DIT, dinutuximab, irinotecan, and temozolomide, which is low-dose chemotherapy, and the dinutuximab, we've seen some high responses with that treatment. More likely than not, if you failed induction chemotherapy, giving more chemotherapy is not going to lead to significant response and will largely just be toxicity. That's where, again, doing something different and using a different modality of therapy, I think, is so important.
Next, the role of radiotherapy to the metastatic sites, which is PET-based, complete metabolic response.
Yeah. So we've done we use MIBG here in the States, but we use PET if you're not MIBG avid. But what we do is we do give radiation therapy to any site of disease that is present prior to transplant. So at the end of induction, when you do your end of induction eval, if you have 3 MIBG sites and your primary tumor, then you'll get radiation to your 3 metastatic sites and the primary tumor. Everybody gets radiation to the primary tumor, and we do radiate sites that are positive at the end of induction. Our radiation therapists do not like to radiate more than 6 sites. So if you have a ton of disease that's left behind, you're probably better off trying, if you can, some chemoimmunotherapy and see if you can reduce that. And then that will be your new baseline of what you would radiate. But we do radiation to metastatic sites that are present.
The children aged 12 to 18 months with stage M whether they are IR or HR.
Right. So we consider toddlers, and again, if you go to that 2021 flow sheet that I showed you that was published on the COG new classifier, if you are 12 to 18 months, so you're a toddler with stage M disease, whether you're intermediate risk or high risk is based on your tumor biology. So if you have all biologic features, you would be considered intermediate risk. And if you have some unfavorable features, for example, unfavorable histology, or if you have segmental chromosome aberrations, then you get bumped up into high risk. So we base it on the biology of the tumor. But you can go and, like I said, look at that flow sheet, and there's a category for the patients based on their age and the biology that's present in their tumor, and you'll see how it's classified.
So the last question, what are your consolidation strategies for relapse neuroblastoma after chemoimmunotherapy with good response?
Yeah, that's another huge question, and we never know what to do. So we have treated patients, like I said, when they relapse or have refractory disease with chemoimmunotherapy. We do not know how many cycles we should give. We do not know if additional therapy is also needed. On the 1221 study, which was the phase 2 study that I presented the data for, that showed the very nice response rates in the phase 2 COG study with DIT, that allowed for 17 cycles of chemotherapy, immunotherapy. And so what we've been doing is we've been treating with at least 6 cycles of chemotherapy, immunotherapy. And if the patient's in remission after 6 cycles, many of us will go for another 2 or 3 cycles. And to know when to stop, it's just totally not clear. And what we've done in a couple of our patients is we've stopped the chemotherapy and just done the dinutuximab alone for a couple of months. And then we kind of have conversations with the family and we say, do you want to take a break? You want to keep coming to the hospital? I had one patient who had relapsed 5 times that I was treating like this, and eventually got the patient just onto antibody alone, and the patient was staying in remission and continued to come. But the family said to me, well, instead of coming every month, I'll come every 2 months. And I said, okay. And then he said, instead of coming every 2 months, we'll come every 3 months. I said, okay. And then COVID hit, and they said, we don't want to come to the hospital anymore. And I said, okay. And that was 2020, and that patient has been off therapy since 2020 and remains in remission. So I don't know. I don't know what the right answer is, but that one patient was treated this way and with a little bit of immunotherapy after the chemoimmunotherapy and did well. The one thing I would do is I would absolutely add radiation. I wouldn't only use chemoimmunotherapy. So if you relapse in a couple of sites, we typically will give 2 to 3 cycles of chemoimmunotherapy, radiate those sites, and then continue on with more chemoimmunotherapy.
Thank you, Dr. Sen. I think we are exceeding time. Would you like to take more questions? Or...
Oh, it's up to you guys.
Okay, there may be one question and then we can stop. A role of dinutuximab in children more than 18 months with intermediate risk in terms of improving the overall survival.
Yeah. So I think that is something that we ought to consider in those stage 4 patients that I mentioned who have unfavorable biology. Their event-free survival rate is approximately 3-year event-free survival rate is approximately 68%. Now, some of them are salvaged, but not all. And the question is, if we were to add in additional therapy, I certainly wouldn't want to add more chemotherapy necessarily, but if we could add in perhaps some antibody therapy, that might improve that particular unfavorable little cohort of patients. Their overall survival, I think, is above, like 75% or something. So the vast majority of the patients do fine, but there certainly is a cohort that do not. And if we could avoid, those deaths, that would be positive. The problem, again, is these are very small patients, very small numbers, very difficult to have a clinical trial for stage 4 babies, and so at any rate, difficult to know what to do.
Okay. Thank you, Dr. Susan, for taking your extra time and having this long discussion. Now I hand over the session to Dr. Manas to close the session. Thank you.
Thank you, Dr. Susan. It was just an amazing session. I think, on behalf of the Pediatric Hematology Oncology chapter of India, we thank you so much for this detailed description on neuroblastoma. It was just amazing. I just have one request, and, it may not be a very appropriate request, but it is a very heartfelt request that, there are these international companies which listen to leaders of neuroblastoma like you. We have examples of, getting drugs like blinatumomab in India because St. Jude, Amgen, everyone worked together to provide blinatumomab, which is a immunotherapy for ALL, to countries like India. And we have like 6, 7 centers where the drug is being provided free. As you said in your talk that, there could be some centers in India where drugs like dinutuximab could be provided, and we could, those can act as referral centers. It's my humble request that at any big platform where you have drug companies, where you have people pushing for improvement of outcome of children in low and middle income countries, please raise a voice for us. Our leaders have been doing that in the international platforms, but maybe there would be some companies who would listen to you and your colleagues who have done such remarkable work in the field of neuroblastoma, and we can have a better access of drugs like dinutuximab for our patients. And I know it's a big ask, but if it is possible, it would really benefit patients, the majority of patients with cancer, because as you know that we have very, very large number of children with cancer in India, and it would be great help for all of us.
Yeah, I absolutely will. A colleague of mine, Wendy London, is actually in the process right now of developing a risk classifier for patients in low and middle income countries. And she has a whole team that she's working with on this project. I will absolutely deliver your message to her and that team, and let's see what we can do.
Thank you so much. Thanks a lot once again. And, please visit us in India. We would love to host you in one of our national conferences. And do let us know your availability for that anytime in the next 2 years. And it would be a pleasure to have you in India. Thank you so much.
Thank you very much for the invitation for today and future travel plans.
Thank you.
All
Thank
right,
you.
guys. So nice to be here.
Thank you so much.
Bye.